Occupational English Test. Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now look at the notes for Extract 1.
Extract 1.
Mr. Smithers?
That's right, Toby Smithers.
Now, I think you've been having some stomach problems.
Yes, that's right, for some time actually.
OK, I've got some notes here, but perhaps you can tell me in your own words about those problems. About any treatment you've been having, or anything else you can remember that seems relevant.
OK. It all started about 9 months ago with a stomach upset.
OK.
I thought I'd caught the vomiting bug that was going round.
Yes.
Basically, I just couldn't keep anything down. No diarrhea or anything, but it was pretty bad.
Right.
Anyway, it cleared up in a couple of days, and I went back to eating normally. The thing was, though, from that time on, whenever I had a meal, lunch or dinner, I'd feel incredibly sleepy almost before I'd finished, and for about half an hour afterwards. I didn't feel tired as such, not in the sense of fatigue. It's just that I could hardly keep my eyes open.
I see. Were you in any pain?
No, none at all. The only other symptom was that I was getting very thirsty, especially at night, so I was drinking a lot.
Right.
So I went to see the doctor, expecting some simple explanation, but she said my symptoms were quite unusual. Well, not the drinking. She explained that the stomach upset had left me dehydrated.
Yes, that's right.
But it didn't explain my other main symptom.
And the dehydration passed?
Yeah, that was just a temporary thing. Then she asked me if I'd ever had stomach cancer, which was a bit worrying.
But you haven't?
No. But then she explained that there's a condition that has similar symptoms to those I had. She didn't think I actually had that condition because it generally affects people who've had stomach surgery, and I hadn't. It's called gastric dumping syndrome.
Oh, yes.
Anyway, what she suggested as, like an interim measure, was following the treatment plan for that syndrome, even though I probably hadn't got it. So I had to keep drinking because I needed to keep my fluid levels up.
Yes.
But not whilst I was eating. So in other words, I had to separate the 2 activities by about half an hour. Then as for the meals themselves, she suggested an eating regime that she called little and often. So, no major blowouts and no skipping meals either.
Sure. Did that help?
Yeah, it did, but it was only meant to help me in the short term. Because meanwhile, I had various tests. I gave a urine sample, went for a blood test, neither of which showed up anything untoward. So I just hoped it'd clear up of its own accord.
But it didn't.
Well, no. The regime worked all right, but as soon as I went back to eating and drinking normally, the symptoms would come back.
OK.
So the doctor referred me for an endoscopy. I saw a gastroenterologist for that. He'd looked at my other test results and examined me and everything.
Sure.
And of course, once the results of that came back, they showed that I'd got Helicobacter pylori.
I see.
So I went on the course of treatment, the 3 drugs for 2 weeks, 2 different antibiotics and an antacid. That's the combination which gets rid of it.
Yes.
After that, I went back for a breath test, and that was all clear. So I thought that'd be the end of it, and I'd be back to normal.
But you're not.
Well, I've given it a couple of months, but the symptoms are the same.
Okay.
If I stick to the eating regime, I'm okay. When I come off it, I'm back to square one. So I'm thinking, sure, the stomach problem that the gastroenterologist found has been dealt with, but that wasn't what was causing the original problem.
And how's this affecting your everyday life?
I can live with it. Obviously, it would be different if I was driving for a living or operating machinery, but I'm a teacher, so it's okay. But to cut a long story short, I asked for a second opinion, and so here I am.
Extract 2. Questions 13 to 24. You hear a GP in a student health centre talking to a patient called Jason Bosworth. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
So, Jason, how can I help you today?
Well, it's a bit of a long story. I think maybe I should have come to see somebody before, Or perhaps I should have gone to the hospital when it first happened. I don't know.
Okay, well, let's start at the beginning. How old are you?
Oh, I've just turned 21. I'm in the final year of a sports science degree. As you can imagine, I get plenty of exercise. I'm generally fit and well, or at least I have been until now, and I've not been plagued by injuries at all, not like some people on my course have. So I guess I've been lucky.
I see. So, what's happened to change that?
Well, what happened was I was out cycling. I reckon I do about 100 kilometers a week usually, and I've never had an accident before, but for some reason, going round a sharp bend, I came off my bike. It was stupid, really.
Okay, and how long ago was this?
5 days ago now. I had a few minor cuts and bruises, but nothing serious, so I didn't go for treatment or anything. Fortunately, I had my helmet on because I did bang my head quite badly. But I felt all right at the time, so didn't think much of it. I was a bit shaken up.
Yes.
But the bike was all right, so I rode home and had an early night.
And you slept okay?
Oh yeah, I was fine. Only thing was, I woke up with a migraine. Now that didn't worry me particularly because I do get them occasionally, so I didn't immediately make any connection with the accident. I just took my normal medication, and as the day progressed, it wore off.
And since then?
Well, I've had no more pain. It's just that I've not been feeling my normal self, really. Like when I was at the gym, I started to get these dizzy spells. Like the room would start spinning suddenly, and I'd have to rest up. I've never had that before.
Okay.
Then at other times, I just don't feel right. It's as if I'm sort of floating. Do you know what I mean? It's as if I'm not quite all there.
Right. And how often do you feel like this?
Well, all the time, really. It sort of comes and goes, but I haven't felt right for a couple of days now. Then sometimes I'm even like unsteady on my feet. I have to hold on to something because I think I'm going to fall over.
Oh dear.
Maybe it's just a feeling, but it's not really like me. Then, yesterday, I got home and I couldn't find my keys. I went through all my pockets and really started to panic because I thought I must have dropped them in the street or something. Then I remembered that I was wearing the little backpack I use when I go jogging, and that's where they were. I mean, I never put them in there. I had no memory of doing that whatsoever. It was weird.
Okay. And has anyone else noticed a change in you at all?
Yeah, I went out for dinner because it was my friend's birthday. We went to this really lively restaurant in town, and the noise started to get to me. You know, it was just people talking and laughing and stuff, but I couldn't wait to get out of there. It wasn't really a great night, and afterwards, my girlfriend told me I'd been irritable for a couple of days, which isn't like me, so that's when I thought I'd better come and see somebody.
Sure.
And another reason is that I've got exams coming up, and I'm finding it really hard to concentrate. I've got a lot to do, so I need to knuckle down.
And is there anything else worrying you? Anything else on your mind?
There is another thing, actually. I've got a really big rugby match coming up. I'm in the college team, and it's the regional final. I really want to be fit enough for that, but I'm wondering if I'm well enough to play.
Okay, I'm beginning to get an idea of why you're concerned. What I'd like to do next is to run some tests.
That is the end of Part A. Now look at Part B.
Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen.
Now look at question 25. You hear a consultant talking to a woman whose father has just been admitted to hospital. Now read the question.
So we've talked about the various things that might have caused your father to collapse. A lot of times we investigate multiple symptoms so as to rule out any life-threatening conditions.
So it could take some time to get to the bottom of the problem?
Possibly. In the meantime, he's quite stable now, and we're encouraged by the progress that he's making.
Well, I'm glad to hear that. But at least he's not in any great discomfort, is he?
According to the assessment at the bedside by his nurse, his pain is well controlled, and we'll try to keep his sedation at an adequate level until we're ready to begin treatment.
Question 26. You hear a trainee nurse receiving feedback from her tutor about the ward round she's just completed. Now read the question.
How do you feel your ward round went with that patient?
Oh, I really should have told him what I was about to do, rather than just rolling up his sleeve to take his blood pressure.
Yeah, it would have been preferable, but at least you realise.
Thanks.
I think you did your observations really well, though. You checked the patient's details are correct, you put the date in, you timed it correctly, you observed that all your parameters are within normal range, and you did the respiratory rate while you were doing your manual pulse.
Yes, the pulse was quite strong and regular.
And you could have passed that on to reassure the patient too.
Oh,
But you look back at the previous observations, put your signature at the bottom. That's all good.
thanks, okay.
Question 27. You hear a hospital nurse briefing a colleague about a patient with chronic obstructive pulmonary disease, or COPD. Now read the question.
So who's next?
The patient in bed 12,
Mhm.
she had a fall at home about a month ago, but she's otherwise independent with her day-to-day activities.
Mhm.
Her falls risk is high given her recent history. She's been assessed by the physio, and she's on a rollator frame to ambulate. Her skin integrity is intact, and she's responded well to all treatment.
Good.
She's on a normal diet.
Mhm.
The observations were last done at 6 a.m., and they were stable. Her medications are IV tazocin due at 2 p.m.
Mhm.
and prednisone next due at 8 a.m. tomorrow.
Okay.
You need to check with the doctors today whether she'll continue with the IV antibiotics and whether the cannula can be removed.
Mhm.
At this stage, they're aiming for discharge in a couple of days' time, pending discharge from the physio and also ceasing IV antibiotics.
Okay, thanks.
Question 28. You hear two hospital managers talking about a training session for people who do voluntary work with patients. Now read the question.
So how do you think the volunteer training course went?
Well, we had a reasonable turnout, considering that these people already give up their free time to drive patients to appointments, visit inpatients, all sorts of stuff like that. It's quite a lot to ask. It's a wonder so many managed to fit in the training too.
And they did seem to get something out of it, if the feedback sheets are anything to go by. From my point of view, though, I just wasn't sure whether it went into issues like customer care, confidentiality, that kind of thing, in enough depth.
Well, that's something we can always look into before we roll out any more.
Well, I think we should.
Question 29. You hear a pharmacist talking to a doctor about a patient's medication. Now read the question.
Sorry to bother you, Dr. Baker. I just wanted a quick word about Mrs. Milton's prescription, the one for anti-inflammatories that you gave her after last week's consultation.
Oh, yes, for her osteoarthritis.
Yes, so she's been on them for a week now, 500 milligrams twice daily. The thing is, she's just been into the pharmacy complaining of a headache ever since she started the medication.
Really? Well, that does happen in some patients, but maybe switching her onto a different anti-inflammatory wouldn't be a bad idea.
Okay, I'll look into some options and then run them past you later, shall I?
Fine, thanks.
Question 30. You hear a surgeon talking to a member of his team as they are finishing a surgical procedure. Now read the question.
Good, there's no more bleeding. The procedure's finished.
Can we just do the sign out? How much contrast did we use?
That was 120 mils of Omnipaque, and we did reach a high dose, so I'll have to fill out a high dose form. I'll do that afterwards. The other thing was that the ultrasound machine was giving us a few problems.
Yeah, I'll have to get the technician on the phone.
Do it now, though, because we'll need it if we're going to get through all our lists today.
Do we need to send this patient up to HDU?
Actually, everything was quite straightforward, so I'd say a regular ward bed is fine.
That is the end of Part B.
Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1.
Now look at Extract 1. Extract 1, questions 31 to 36. You hear a sports physiotherapist called Chris Maloney giving a presentation in which he describes treating a high jumper with a knee injury. You now have 90 seconds to read questions 31 to 36.
Hello, I'm Chris Maloney, a physiotherapist specialising in sports injuries, and I'd like to present a case study to give you an idea of the sort of work I do. It features a very successful high jumper in her mid-20s who was referred to me with severe pain in her right knee, and that's the leg she takes off from when she jumps. What's more, when she stepped up her training in preparation for a big competition, the pain worsened, and she'd been forced to pull out of the event. After that, she'd taken several months off training to rest and get treatment from various therapists. To her dismay, however, not only did the pain continue, it actually got worse, meaning she was unable to do any strength training, let alone jump-specific work. By the time I saw her, she was on the verge of giving up, having lost virtually all belief in her ability. My initial assessment quickly confirmed patellar tendinitis in the affected knee, accompanied by some swelling and significant tenderness over the lower part of the kneecap. This wasn't difficult to diagnose. I also noted that she was slightly overweight for her height and had rather flat feet, but that's not so unusual in high jumpers. Further assessment revealed that the gluteal muscles connecting the hips and thighs were considerably less sturdy than you'd expect in an athlete of this calibre, and both the lateral retinaculum connecting the patella to the femur and the iliotibial band, the ligament running down the outside of the thigh, were tight and tender. As a first stage, I was keen to show I could help by relieving some of the pain, so I worked at loosening her lateral retinaculum to see how much of the tendon pain was due to inflammation and how much came from restriction of normal patellar movement. This manipulation and massage instantly cleared the pain she'd felt while doing a single-leg dip exercise, where you stand on one leg and bend the knee. This indicated that her tendon pain was most likely due to patellofemoral joint dysfunction, caused by muscle imbalance and poor biomechanics, and not by an active inflammatory process or partial tear in her patellar tendon. So an MRI scan wasn't needed. The treatment continued along similar lines for some weeks, with loosening of the lateral retinaculum and deep tissue massage of the iliotibial band and other muscles. One option at this point was something called taping. This is a way of reducing pain so that athletes can continue with strength exercises. But it seemed clear from early on that we shouldn't put taping on this patient's patella and tendon until she started jumping again. She was getting pain relief and progress simply from the manual techniques, and taping might have led to problems later on. Athletes often become dependent on tape and other accessories. In other words, instead of aiming for 100% muscle strength and joint position control, they settle for 80% plus artificial support. The patient also had a specially designed program of gym activities. Although she needed to restore power to those muscles affected by inflammation and tenderness, the priority was to get her posture and alignment right. She started by doing double leg squats with her back to a wall in front of a mirror so that she could see whether her feet were arched and if her knees were over her feet. She also did squats while squeezing a ball between her knees. There was light leg press work, followed by single leg stance work, first static, then on wobble boards, and with elastic resistance. She progressed to moving on and off steps, sometimes holding weights, all the time paying close attention to positioning and muscle and joint alignment. The next stage was to liaise with the patient's coach. She began running, jogging for stamina, and then sprint sessions. Work on power was stepped up gradually and included some weightlifting. After some analysis, we also decided to modify her run-up to the high jump bar. By beginning from a wider position and running in with much less of a curve, there was much less of an impact on the ankle, knees and hip, especially in her right jumping leg. Interestingly, the patient reported that remodelling the run-up felt fresh and motivating and helped to reinforce the sense she had of being a reborn athlete. Once the rehabilitation process was complete, she was able to compete without pain and free of any reliance on taping or knee strapping. So, before I go on to the next...
37 to 42. You will hear a plastic surgeon called Norma Woolston giving a presentation about surgical treatment for a condition called Dupuytren's contracture. You now have 90 seconds to read questions 37 to 42. My name's Norma Woolston, and I'm talking today about surgery for a condition called Dupuytren's contracture, with a particular reference to a case I treated recently. Dupuytren was first described by a French physician of that name in 1834. It's a condition in which one finger becomes increasingly bent in a flexed position. The first sign is a formation of small hard nodules in the palm of the hand, but early diagnosis is relatively unusual because there is no associated discomfort. In its early stages, the condition may respond to steroid injections and physical therapy, but this doesn't necessarily halt its progression. The affected finger often becomes increasingly bent and can no longer be straightened. But patients tend to present with the condition only when manual dexterity is compromised, by which time surgical intervention is indicated. My patient, let's call him Eric, presented with quite an advanced case of Dupuytren's affecting the little finger of his right hand, a relatively common site for the condition, although a physical examination revealed that he was also developing the first signs in the thumb on the same hand. Eric was then a 61-year-old office worker who used a keyboard regularly. There isn't very much published so far on the causes of the condition or what might exacerbate the symptoms, but the digital age doesn't appear to have resulted in an exponential rise in the number of cases reported. Eric was finding the condition inconvenient and uncomfortable rather than painful. It was becoming tricky shaking hands with people, and holding a pencil was becoming a challenge. Eric didn't recall any family history of Dupuytren's. That's not unusual, but doesn't in itself mean that there was none. Indeed, we know that the condition is often present across the generations of one family. But because patients don't typically develop symptoms until late middle age or later, it often goes undiagnosed or doesn't develop to the point where it requires treatment. Indeed, mild symptoms are often attributed to mild arthritis or the general effects of aging and wear and tear. Nor did Eric report any of the other associated risk factors, such as smoking, diabetes, or low body mass index. It's worth noting, however, that he was of classic Northern European appearance, tall and fair-skinned, and Dupuytren's is known to be much more common amongst Northern Europeans than in other populations. In Eric's case, the condition had progressed to the point where surgery was indicated. It was clear to me that what was required was a fasciotomy to straighten the finger. Eric had some misgivings about this, as he'd heard about less invasive treatment options. But I explained to him that, taking into account the extent of development of the diseased tissue and the specific site, this was the only option, and he agreed to go ahead with the procedure. Fortunately, Eric was generally in good health, was taking no medications for other conditions, and had no concerns or negative history relating to general anaesthetic. This was much the preferred option because, although the surgery isn't lengthy, usually between 30 and 40 minutes, it does call for a complete immobilization of the hand.
After the procedure, Eric was using a sling and pillows at night to hold the wound site high up and so prevent a build-up of fluids. I'd explained that wearing a sling when out and about also provides a degree of general protection. It's a remarkably effective way of signalling to other people to keep their distance, as the hand is very sensitive to knocks. But actually, he'd taken plenty of time off work, so this hadn't been a problem for him. Indeed, when I saw Eric at the follow-up appointment, the wound was healing well. His note showed, however, that the sutures hadn't all fully dissolved after surgery, and that this had been a source of discomfort. Worried that perhaps there was an infection, he'd consulted a nurse, who'd removed them and also taken the opportunity to excise some excess scar tissue, which had formed at the site. I reassured him that this was by no means unusual and wasn't a cause for concern. I was pleased to see that when he returned for the final consultation, Eric's wound had generally healed well. As is the case with many Dupuytren's patients, however, Eric volunteered that, despite my careful explanation at our first consultation about the treatment and recuperation period, he'd entirely underestimated the impact of the surgery on his daily life and how long the disruption would continue. That said, his finger is now much straighter. This treatment for Dupuytren's never completely straightens the finger, nor restores full use, but he'd been aware of that from the outset and had no complaints on that score. So far, apart from the initial indications in his thumb, there is no sign of recurrence, although this is relatively common, especially over time. I reflected, however, that perhaps being very familiar with the condition and having performed this kind of surgery many times, I hadn't made it clear enough to Eric exactly what to expect after the surgery. What Eric's case made me realise is that